very much for giving me the opportunity. Is it switched on? Not really. Better now? Better now? Yes. Okay. So again, thank you very much for giving me the opportunity to look at the other side of the coin. And you have seen that Piet Juneman is a brave surgeon. He can do it. But the question is, does it make sense? And I don't think so. And I will give you some arguments showing that, yes, technically feasible, but probably not meaningful. So who of you have seen patients like that? Patients who are coming back after radical prostatectomy, bringing you a PET CT scan, PSA is 0.5, showing you a picture like this, saying, doctor, this is probably the source of my PSA recurrence. Who of you have seen such a patient in your practice? Almost everybody, obviously. So have you seen this patient 10 years ago? You have seen 10 years ago? Have everybody seen you 15 years ago? No, but you have seen patients with PSA recurrence 15 years ago, right? So this is the phenomenon. Patients coming now with PSA recurrence is nothing new. The only thing is now they bring us pictures for potentially sources of PSA recurrence. And so they put us in the position to answer, does it make sense to go for this thing and take it out? And I think this is growing. This is a growing role because the imaging is getting more and more space. We're talking about MRIs and all the other upcoming techniques. And this question will approach us more and more in the next years. So you just showed me that you are all surgeons. So we have something genetically inherited that there's a problem, we want to take it out. It makes sense, we think. But now the question we have to, or at least what we have to tell the patient, even after the convincing talk from Piet Juneman, that we should inform the patient that at least at the moment, we have to inform him that he will not benefit from that. And I will give you some data on that. So the problems I see with salvage lymph node dissection are 6 problems. We know that the imaging in case of radical prostatectomy recurrence is not precise. Data will follow. The only effect we have seen so far is PSA recurrence or some effect on the PSA. And if the patient benefits in the way that PSA drops for some time, this time is usually very short. And that's a very important thing. The drop in PSA has seen only in this early PSA recurrence, in PSA recurrences that are very slow, that come late. So these are probably patients, those who benefit are those who don't need any surgical intervention at all. It has potential complications. Piet Juneman just said that it's a demanding surgery, sure. And finally, if we look at the survival rates, the cancer-specific survival rates, with hormonal therapy alone, and you will show that, and remember the number that Pete just showed you, 80% at 5 years. There are data out that's showing 90% at 10 years with hormonal therapy alone, so have that in mind. PET CT scan, that puts us under pressure. We see this spot and we have to take it out. That's what the patient is asking us. You've taken the prostate out, why don't you take this out? You are a surgeon. So sensitivity of PET CT scan. The positive predictive value is not bad. So if there's a spot and you take the lymph node out, there's very often cancer in that. But it's not 100%. The best I found was 90%. But there was another study saying that positive predictive value was 23%. So the chance that this spot was something different than prostate cancer recurrence, than prostate cancer was even higher. And the bigger problem, I think, is this one. Sensitivity. So if you look at the histologically proven lymph node metastases that were taken out, only the minority of them has been shown in the PET CT scan. For example, this from Munich, only 40% of those positive lymph nodes found in the histology have been shown by the PET CT scan. So in other terms, we actually don't need this. So if the patient has PSA recurrence, yes, he must have some cells that are producing this PSA, and it's more or less meaningless whether they have a PET CT scan or not. I actually talked with Deria Tilki from Munich, who is now in our center, about her publication, and she did that in European Urology. And I said, and I asked her, what is the consequence of all these data you found? You only found a 5% sensitivity. What are you doing now if a patient recurs? Do you do a PET-CT scan? And she said, no, we don't insist on that, but we take the lymph nodes out. So that's a different situation, certainly. This is another, like a review paper 2 years ago from Dr. Ullmann. And he showed as well that the positive histology, if in a positive PET-CT scan, was about 70%. So that's probably the number we have to keep in mind. 70% positive histology if there's a spot in the PET-CT scan. So the effect of the surgery when you take lymph nodes out, salvage lymph node dissection, has so far only been shown on PSA. So as this is a new approach, we cannot blame it, certainly, that there's no data on metastasis-free survival or cancer-specific or overall survival. But at least we have to inform the patient about that. The patient needs to be informed. Only PSA has been shown to be affected. Does it make anything a difference in the course of the disease? We don't know. This is by far the best paper, to my knowledge, from the Montorsis group. And I want to show you, especially, you have to look on details of these few studies when you judge them. So if you look at that paper, 72 patients, and this is written in the abstract. 72 patients, and the PSA response was 57%. So you think, that's not bad. Patients who recur after radical prostatectomy, 57% have a PSA response. And then you go back to the details. So only 28% of those had no hormonal therapy. Okay, so you look at that 28, only effect of salvage lymph node dissection, 86% of them recurred in the time of the follow-up. And then you look at those 4 patients out of that 72 who did not recur, and these are the patients with the shortest follow-up, which is 14.9 months. So that is the effect we have out of these 72 patients. And it's always interesting if you look at one paper and you get completely different conclusions. Like Pete said, this is an excellent study showing the effect of lymph node dissection. I say, yeah, this is the excellent paper, but showing there's no real effect of lymph node dissection. Progression-free survival, 2 years. You see there's one patient after 3 years who has not yet get a biochemical progression. These patients have been as well irradiated in a large amount of cases, in addition to the salvage lymph node dissection. So we go back to the Rigatti paper. So what they did, because these people are very smart, they look at risk factors. They look, how can we predict those patients who might benefit from salvage lymph node dissection? And what they did, they found out some characteristics. And I want to keep your eye on this one. So those patients who have a low PSA, they are more likely to benefit, react with the PSA. Those patients who recur late, more than 2 years, they have the potential to drop on the PSA. And those patients who are lymph node negative at the initial surgery are more likely. So these are the patients who have a very good course of their disease anyway. Late recurrence, slow recurrence, no positive lymph nodes before. These patients who potentially benefit are those who definitely do not need surgery. And you have to keep this in mind, the point in time when the recurrence is coming, because I'm going to refer to that later on. More than 2 years is favorable. The argument I sometimes hear on that, and I do not agree with that, is that even if we don't cure the patients, we might delay the onset of hormonal therapy. And this is a success of surgery then. And I do not agree with that, because if I want to delay, for example, hormonal therapy in a patient, and remember that in the Rigatti paper, the average median PSA of those patients who received that surgery, the median PSA prior to that was 1.5. Who of you is starting in a patient who had recurred local therapy, radical prostatectomy, maybe salvage radiation therapy, who of you starts hormonal therapy at a PSA of 1.5? You would do. Yeah, we disagree. Pete is the only one. Anyone else? Okay, you never want to be in a minority, but you are, Pete. Okay, so it's, I wouldn't start either. So if I would say a delay, why don't we start at 5? So we delay it for years, so we don't need surgery, just raise the cutoff for initiating that. So that's not an argument for me. And the other thing, maybe you can think, okay, if we delay it, if we do not expose the patient for a long time with hormonal therapy, we might delay as well hormonal refractory status. But I do not think that is true. So what we've learned from all these intermediate hormonal therapy trials, that the rate or the incidence of hormonal refractory disease is not depending on the time we use the hormonal therapy and so on. So I don't think that is at all an argument for doing surgery in these patients. And Pete has just said that it's a demanding surgery. It should be really in the hand of experts. And I just want to give you an example from the Rigatti paper as well. And we all like the Clavian-Dindo classification, and I just looked at this up and compared it to an open radical prostatectomy surgery from Dr. Noldus, and I've just chosen this paper because it's both use the Clavian classification. And you see, looking at the Löppenberg paper from Herne, 2,500 patients, and Rigatti, this is the grade 2 Clavian classification complication of 20% of salvage lymph node dissection compared to open surgery. And you see it's pretty much the same. So we are not talking about nothing. It's a demanding surgery, as we both agree. And so we have to tell the patient, you have demanding surgery, you have a complication rate comparable to radical prostatectomy, and you probably don't benefit. And this is something, my last point, you've just shown maybe certainly the patient selection is a bit different, but I do not think that there's a lot of room for improvement in these patients. So the cancer-specific survival of men who recur after radical prostatectomy is pretty good these days. And I want to show you two series on that. This is from Stephen Borjan from the Mayo Clinic. And you see these are all patients, radical prostatectomy, PSA recurrence. And you see at 5 years, 98%, and at 10 years, 90% cancer-specific survival. And this is from our group, Thomas Stoiber, 97%, pretty much the same in the Mayo Clinic, and identical numbers at 10 years. So the only patients who can potentially benefit from a salvage lymph node dissection are those who die, and even after 10 years, it's only these 10%. So again, there are some smart people, especially behind this paper, and they looked at who are those who are at harm after PSA recurrence to die from prostate cancer. And they characterize these patients. And you see who is at highest risk to die? Those who have a very early recurrence. And going back to the Rigatti paper, those patients who benefit from salvage lymph node dissection are those who have a late recurrence. So obviously, those 10% who might benefit are not those who benefit from salvage lymph node dissection. So I conclude with a look back to the guidelines, which I think is a very wise summary of the non or existing data, or the data that are there. It is experimental if you do that, should be discussed individually. I'm absolutely sure you're doing that. And I think it's good that somebody is doing that to create data, but as well, I do not think that's, at the moment, a convincing concept. So let me conclude. The data are limited. This is a new thing, so we have to wait. But the available data, those things I read about it, are not convincing me to offer that to my patients, because I think that only those harmless recurrences, we talked about that, those with a late recurrence, they had a drop in PSA for a short time. The complications are there, and there are proven alternatives at hand. We've seen papers looking at all these things coming up now with abiraterone and so on and so on. So we have, I think, smarter ways to help our patients. Thank you very much.
Thank you very much. So we are open for discussion. Are there any questions or comments from the audience? Please.
You both showed that imaging is really the limiting factor, and there are maybe some progress with PSMA, PET scan. Do you think when we have better imaging, this will change our pattern? Because when I remember when I was trained by Hartwig and we did radical prostatectomy, we sent out all the lymph nodes, and if one lymph node was positive, we stopped surgery. So, and now we do it in different ways. So maybe with better imaging, we can better identify patients who may benefit.
So, okay, my answer to that is yes, there are more. Just recently, PSMA tracers and so on. There will be techniques who will be more specific, but I think that will not solve the problem, because we have to talk about a principal way. This is a systemic disease, and even if we see something, there are so many things we do not see. And the question is whether it makes sense to pick parts of the disease out or not. And I think that it might make the problem a bit more difficult, more different, and so on, but it will not solve the problem better, imaging techniques. I do not think so.
I fully agree what you said, except for one additional point. I think that it will help you to limit your area where you have to do the surgery on. Otherwise, you have to take them out all, because it's not the problem that we missed some of the nodes. I think it's the problem because it's already an ongoing disease in at least most of the cases. But I think for the initial treatment, it might help. Because what we're going to do in the future, I'm pretty sure, and I'm really wondering how good our results are. We are looking at the T3B patients who have positive nodes, and we do an extensive lymph node dissection initially, and to see how the Gleason 4 or 5 patients, how they do when you do such a kind of treatment, not going up to the bifurcation, but maybe we have to when we have such a kind of imaging beforehand at the primary treatment. And it's not only surgery, it's also radiation therapy. It's the same thing. But to offer radiation therapy in somebody who has recurrent disease with positive nodes makes absolutely no sense. There is no single paper that shows us that this is beneficial for the patient. The only problem I have is that then I have to do, when the patients are up, do a surgery in an irradiated patient, which is a pain in the neck, of course.
Yes, please.
Just two comments. Really great talks, and I think this is an emerging area, and the truth is probably somewhere in the middle. My one question was the value of choline PET-CT, I thought, was largely to exclude local recurrence, because I don't think you want to take this approach in patients who have local recurrence. So in that sense, the fact that the positive predictive value for nodal metastasis is not great becomes a secondary issue. And my other question is the debate here the concept or the application? Because it seems to me, although Markus makes a great point, there are these selected patients who probably benefit. Or do you think that really the actual concept is bad and it's not likely to benefit anyone, or at least benefit outweighing the harm?
So good question. And I certainly, this is not the first time I think about this question, because I think there's one patient who came from our series who had a salvage lymph node dissection, who is free of PSA. So this patient made me think about, yeah, he probably has benefited from that. But on the other hand, we have another 10 patients. We have done 3. They all recurred with PSA. And we have another 10 patients in our database who had a salvage lymph node dissection outside, who recurred almost immediately with the PSA. The PSA was not affected. So yes, there must be a very specific patient outside there who might benefit. But on the other hand, if it is such a limited lymph node metastasis, the only source of the PSA, well, does this patient need surgery? I'm not convinced. I think the concept is wrong.
I have to make 2 points, which you mentioned also in your presentation. One is early rise in PSA, recurrence in PSA. The vast majority of these patients had an early increase of PSA. So this is the worst situation you can see in the patient, of course. So for me, it was clear they all had lymph node metastasis. But a very good point, you have to exclude the local recurrence, of course. The second thing is, unfortunately, or maybe it's good, only 6 of these patients came from our own institution. And there might be a reason that we do initially an extended lymph node dissection in the Gleason 4 and 5 patients. And those are, out of these 6, these are the 4 patients, or the 5 patients actually, who actually didn't show a PSA recurrence within 5 years. So if you do it early enough, and that has to be proven, you are absolutely right, nobody has shown that. If you do it in an early case, who probably has even a delayed PSA rise or even less tumor burden, it might even cure the patient. I have no idea, I can't answer this question. But the vast majority of the patients, they were non-responders. Remember, non-responders to anti-androgen therapy. The next step would be chemotherapy or abiraterone. This is a complete different group from what you demonstrated. And I can't explain it to you why they respond again, but 50% do within 5 years. And I'm sure that others will show up who do not respond later on, of course, but again, all of them are still alive 7 years or 8 years afterwards.
I just want to make a comment on that, because we had this discussion, this is the 3rd time, and
maybe
it's the last time we do it together.
No, I hope not.
So I do not believe that. Honestly, I cannot believe that. It's beyond my imagination. So what he just told you is, these are patients, there's a large, patients with hormone refractory disease who undergo salvage lymph node dissection, and then they respond to hormonal therapy.
Yeah.
I cannot believe that.
I can show you the data.
Can anybody of you believe that? Raise your hand, the one who can believe. You! Oh, here's he's a robotic surgeon.
So now the point is, it depends on what the clone of what clone of the prostate cancer cells are in the lymph nodes. What clone of the metastatic cells are in the lymph nodes, and what is the part of the, because there might be patients that have no more PSA response to hormones in the prostate or in the tumor, but maybe the hormonal clones that have metastasized into the lymph nodes are still responsible or responsive to hormones.
Which means
A man with fantasy.
without further
you're right.
biology, without knowing the load of the tumor circulating cells, you just can't rely. Sorry. It's unlikely that you'll be able to rely only on the image. You need more than that. So if you want to choose and pick the patient that will, and we all have 1 or 2 such patients, you probably, it's likely not ethical to submit 100 patients to get one unless you have additional studies showing which one are the good ones.
I also have a comment. I think there's only one solution to this. Few patients, it is this kind of surgery, you must do a randomized study. I think that's the only solution. There are few patients in each center. Before going on and doing this in individual patients, I think it's even ethical. You should do a randomized study before. Otherwise, you will discuss this for another 10 years without knowing.
Yeah, yes, thank you very much. I think this is the key point, that for such a very rare disease and difficult indication, this would be actually the solution to get us further. I think now we have to stop. I would thank you for this